even better. Microphone. There you go. Good afternoon. Welcome to Grand Rounds. My name is Tom Felden. I'm an organiser of Grand Rounds. More people coming in? No. Grand Rounds continues, and this week, the haematologists, staunch supporters of Grand Rounds, you're always here. So it's great to see you here, and it's great to hear you present. And this week, Karen Boyd is going to talk about single unit transfusion. I have no idea what that means, other than it's perhaps just one unit. Doesn't seem like one unit will go very far, but perhaps I've got the wrong end of the stick. So I understand she's going to come and talk about a quality improvement project involving care of the elderly, and I look forward to hearing what you've got to say.
Thank you. So I'm Karen Boyd, one of the haematology registrars, and as Tom said, I'm here to talk about single unit transfusion, if my voice lasts long enough for that. So an overview of what we're going to talk about today, a bit about the idea of the background behind the idea of a single unit transfusion policy, our aims of transfusion and any alternatives that we may not be using, the audit that I did in care of the elderly and results, and a bit of an update on the audit as well and changes in future planning. So as Tom said there, often people's ideas previously was that if somebody needs a blood transfusion, then they usually need 2 units, and what's the point in giving somebody 1 unit? It won't do anything, or it's not a sufficient dose. But things are beginning to change, and thought process around this is beginning to evolve, and actually NICE guidelines more recently have placed emphasis on a single unit transfusion followed by reassessment. This doesn't apply to bleeding patients or unstable patients or those with bone marrow failure, but especially in elderly people, you might find that they actually increment a lot better than expected with just a single unit of blood, and they might not need that second unit, so you'd be exposing them to unnecessary blood product, with them basically having had a dose that's sufficient already if they've had a single unit and are better. And along the same vein, sorry about the pun, there are restrictive thresholds, as in, I'm talking about hemoglobin of less than 70 or less than 80, or are being looked at recently, and it's lots of evidence to suggest that these aren't harmful. I'm going to come on to the evidence for that and also second. So it's just all about rational transfusion. So rational thresholds rather than restrictive sounds better, and targeting reassessment in between units. Despite all of this, excessive transfusion is very common and it can be harmful. And really, single unit transfusion policy is trying to rationalise blood use, and it seems like a very, very sensible way of doing it. There was a pilot study down south in Kings, and that resulted in a 40 to 45% reduction in red cell use over a 6-month period implementing the single unit transfusion. So it seems like an effective way forward. So there's lots and lots and lots of trials, and I don't have enough time to go into absolutely all of them, but just a kind of overview of the main ones. With regards to restrictive or rational targets. The first one back in 1999, the first main one was the TRIC, which was intensive care patients, about 1,000 intensive care patients, and they were randomised to either transfusion threshold, and this is in the absence of symptoms, of less than 70 or less than 100, and there was no difference in mortality between those two groups. However, this trial, only 13% of people screened actually were randomised, so it was criticised a little bit for that. A more recent one in septic shock patients, the TRIS, again, between or less than 70 and less than 90, and again, there was absolutely no difference in mortality between the two groups. There's often a kind of trend for improved outcomes in the restrictive transfusion groups. And actually, the surviving sepsis now recommends a threshold of less than 70 unless there's extenuating circumstances. Usually, the restrictive or rational transfusion and single unit doesn't apply to bleeding patients, but I thought the transfusion strategies for acute upper GI bleeding paper was quite interesting, and in fact, it suggests that there was a Spanish study that was published in 2013 in the New England Journal of Medicine, and actually suggested that those assigned to a restrictive transfusion threshold did better than those with a liberal transfusion threshold and actually rebled less. BMJ systematic review of 31 trials and almost 10,000 people showed no difference or certainly no detriment in using a transfusion threshold of less than 70 or less than 80. It's a kind of a mixture in amongst the trials of different thresholds. The only thing is, in those with ACS, another BMJ systematic review, acute coronary syndrome, obviously ACS stands for other things, and those with cardiovascular risk factor that might not be safe to use a threshold of less than 70, so aim for over 80 in those with coronary artery risk factors. And that's not in terms of mortality, they've got the same mortality, it's just that they had a 1.76 times the risk factor for having an acute coronary event. But bearing in mind all the above is in those people that are not symptomatic of anemia and you're transfusing kind of based on numbers, which we probably shouldn't be doing. But if your patient's very symptomatic and they have a haemoglobin of 80 and you think that they're symptomatic due to their anemia, we're certainly not suggesting that you withhold the blood. It's just bear all this in mind before just transfusing and not thinking about things. So blood transfusion nowadays is very, very safe. But you still don't want to expose somebody unnecessarily to a human product. There is a risk of alloimmunization if you give somebody blood. Obviously, that's not something you want to do unnecessarily. Transfusion reactions, for instance, febrile transfusion reactions, are much less common since leukodepletion, but they do still occur. Thankfully, more serious transfusion reactions like ABO incompatibility are very, very rare and usually caused by wrong blood in tube or wrong patient. However, an important one to highlight is transfusion-associated circulatory overload, and that was highlighted in the 2016 SHOT report as a major cause of morbidity and mortality. And especially in elderly people, if you're giving them 2 units of blood, not reassessing them in between, not giving them diuretics, then it's a real risk that they might get overloaded with that. And that's definitely something that's avoidable as well, particularly if the transfusion itself was avoidable in the first place. And thankfully, serious viral transmission is now very, very rare, less than 1 in a million. So very obvious points, but something just to go over again. Alternatives to transfusion. Really, when somebody is anemic and we're considering blood transfusion, we really should be looking at the cause rather than just transfusing and sending them home. I noticed that quite a lot of people tend to get IV iron, and that's often with a high ferritin. I think there's a bit of confusion when people just check iron studies or maybe ignore the ferritin. Iron studies aren't terribly reliable, a lot of diurnal variation in iron, and it's also an acute phase. And generally, even if they're unwell and have a high CRP, if their ferritin's over 100, they're usually not iron deficient, so wouldn't really benefit from IV iron. But it's certainly always worthwhile checking their ferritin plus or minus iron studies. B12 and folate we tend to forget to check more often, and it's definitely something to remember, particularly if they're macrocytic or if there's any other cytopenias. And a bit rarer, but if bilirubin's elevated, always consider doing a hemolysis screen too. Most people, certainly in the care of the elderly wards, actually were just anemia of chronic disease. Obviously with renal anemia you can think about EPO, etc. So obviously always try and treat these reversible causes before we rush in with transfusion. I'm not going to go through this entire table, but as mentioned, iron is fairly unreliable, a lot of variation. The only true test is a low ferritin confirms iron deficiency from iron studies in ferritin. This is a nice wee traffic light system that I found online. It's just reiterating to think before transfusion. Usually a haemoglobin of less than 70, it really will be appropriate, and over 100 really not appropriate to transfuse somebody. And then you've got the wee amber area in the middle where you can consider whether they actually need it based upon symptoms and patient tolerance of anemia, etc., and whether there's anything else you can do first. So the decision to look at the care of the elderly wards as a first set of patients was based upon the fact that elderly people are more at risk of the hazards of transfusion. Often they will increment more because they've got low body weight. I thought it was a good place to start to promote rational blood use and single unit transfusion reassessment is really what this is all about. So through Traceline, anybody issued with red cells during the whole of 2016 were identified and looked at a single unit transfusion, which was just deemed 1 unit within a 24-hour period, and then looked at the increments, whether they were reassessed between units, also looked at whether there was any reversible cause sought, like whether their ferritin as well as B12 and folate or iron were checked. And then I also recorded whether there was any adverse events encountered. So in total there were 53 patients and they received 119 units in total of red cells in 2016, and of those, and this is who the single unit transfusion policy would apply to, there were 40 stable non-bleeding patients and they received 78 units. And when anybody received a transfusion of any number of cells during more than one 40-hour period, I just looked at their first event. So this was a graph of the red cell issue, units per person. Obviously those that were bleeding, unsurprisingly, received more units at 3.3. Overall, about 2.2 average per person, and non-bleeding, actually fairly reasonable, 1.9 unit per person. So the mean age was 84, although there were patients up to 97 that received transfusion, and just under a third, so 12 out of 40, already received a single unit transfusion, which I thought was a fairly good starting point. And 16 of 40, so slightly more than a third, were reassessed after their first unit. And the further analysis that I do from here on is just of the stable non-bleeding patients, so excluding the bleeders. This is the proportion, a smaller proportion got 1 unit compared with 2 or more, and slightly more being reassessed after their first unit. So the average pre-transfusion hemoglobin was 74. We've talked about just their triggers of less than 70, but I think sometimes elderly people don't tolerate anemia as well, so 74 is reasonable. Although maybe overshooting a bit with a post-transfusion hemoglobin of 100. It's probably not necessary for these patients. It wasn't much of a difference between the single and multiple unit what their starting hemoglobin was. It may have made a bit more sense if those with multiple unit transfusion started off much lower, but that wasn't the case. And as expected, the average increment, or the mean increment, was 12.5 units, grams per litre per unit even. And that's just generally because these people are old and a bit of lower body weight. And about a third actually incremented more than 15 grams per litre. So if you do recheck, you might be surprised. There was one that actually incremented 36 grams per litre in a single unit transfusion. So reasonable reassessment, I thought, for a starting point, although multiple unit transfusion is still fairly common, and it's still fairly common to just cross-match 2 units and not think about it, give both and not reassess. I mentioned that I was looking at reversible causes or whether they'd been checked as well, and they had in just over half. Probably could have been done in more patients. I didn't include the people that just had iron. I had included the ones that had iron and ferritin checked. And of the 22 that had ferritin, iron or B12 folate checked, there were 6 of those 22 that were abnormal. So most of them, as I said, were anemia of chronic disease. Reminder to not give 2 without review. So any adverse reactions? Yes, there were 2 patients, which doesn't sound like a huge amount, but actually I think it's quite a lot. 5% of the patients had X-ray changes that were consistent with pulmonary edema in the 48 hours following transfusion, and that would be compatible with transfusion-associated circulatory overload, and really should be assessing these patients before, seeing whether they're at risk of TACO, seeing whether they need diuretic cover with their blood, and really reassessing them between units. Both of those were ones that had multiple unit transfusions as well. There weren't any other adverse events that I could see from ICE or portal details. And points for consideration with electronic issue, it's not like it's going to take a very long time to get another unit. If you do decide that you want a second unit, it's really pretty quick. Another side point is, out of these patients that I looked at in the care of the elderly wards, almost half of them have now died, which really does reflect the fact that it's a very elderly population. As I said, the age range was up to 97. However, obviously those in the last stages of life, they may not really feel the benefit from blood as much, and it may not really be appropriate to transfuse them, but obviously that's a clinical decision. So after this audit, fed the results back to the Medicine for the Elderly doctors and did a presentation, education on that. Made the groundbreaking step of putting up some posters and some stickers in the doctor's room, and we also implemented a policy change as of April last year. So then thought we'd re-audit and have a wee look at a 6-month update. And this is our NHS, this is our new NHS Tayside blood transfusion guidance, which just talks about what we said before with the transfusion trigger in the absence of significant symptoms of a haemoglobin of less than 70 or less than 80 in those with coronary artery disease. And again, based on symptoms, reassess after the first unit. So a 6-month update of May to October inclusive is what I've looked at next. And this is just excluding any unstable or bleeding patients. So this is solely the stable non-bleeding patients that the single unit transfusion policy applies to. So this time, 16 patients received transfusion, and a significant decrease with a mean or average of 1.3 units per person. So I thought that was a pretty good reduction. And 13 of these 16 that were transfused were reassessed between units, which was great. One that wasn't reassessed, I thought was worth mentioning, had a haemoglobin of 47, so I think it's reasonable that they thought that 1 unit wasn't going to do for that patient. The average haemoglobin was 72 to begin with, so similar to previous, which is fine. Again, elderly people might not tolerate anemia as well. And the post-transfusion haemoglobin was... Where is that noise coming from? How do I turn that off?
Might be the first people speaking. You just ask the person to mute their microphone.
Could the Perth people mute their microphone? I can just talk louder then.
Absolutely fascinating.
I'm just wondering if there's something I can press on here. Oh, there we go.
My very presence has shut them up.
That's all it took. And the post-transfusion haemoglobin was slightly less this time at 94. Again, mean increment more than we'd expect, with a mean increment of 16 grams per litre, with a couple of outliers again this time at 35 grams per litre and 28 grams per litre. They're smaller numbers, which explains the difference there. And there weren't any adverse events identified this time, which was really good. And a nice graph of the significant increase in reassessment between units, so from 40% to 81% that were then reassessed between units. And the average issue, 2016, and then the 6-month update. This is a good reduction. So, in conclusion, the single unit transfusion policy seems like a pretty rational way of reducing unnecessary blood transfusion. Seems to be safe. Using rational targets as well will further reduce unnecessary transfusion. The aim obviously is to rationalise rather than restrict blood product. If somebody needs a transfusion, then there's no way that you should be withholding that for any reason. It's just more whether they need 2 rather than just 1. Staff education is obviously key in implementation, so ward doctors, consultants, nurses, obviously lab staff as well, maybe suggesting that if somebody is asking for multiple units in a stable non-bleeding patient, whether we challenge that. Patient education, do I really need the second unit? The patient can be asking, and going along with the Choosing Wisely campaign. We have already audited, myself, Chandra and Katie, the orthopaedic wards. There was another study called the Focus study in 2015, which showed that those with cardiovascular risk factors post-hip replacement assigned to haemoglobin or transfusion trigger of less than 80 or less than 100, there was no difference in all-term mortality, ACS events, or ability to walk across the room at 60 days. So audited the orthopaedic ward, fed the results back to them, and we're trying to emphasise rational and single unit transfusion policy in the stable post-op patients there. Obviously it doesn't apply to those that are bleeding or intraoperatively. And in general, reassessment, always a good thing, always a positive thing. And reassessment between units may help reduce complications such as transfusion-associated circulatory overload, as well as preserving blood for those who actually need it. And a very special thanks to Katie and Chandra, who helped with the audit. Has anybody got any questions?
Right, super. I think this is fascinating. I'm sat there thinking, I've been giving 2 units of blood to people since I was a house officer in 1900 and oatcake. And I was just thinking, why do I give 2 units of blood to everyone? And I do. I mean, you're nodding away over there. I mean, I've always given 2 units of blood to people because my SHO told me in 1999 I should give 2 units of blood to people. And I suspect that she was told by her SHO, and that's it. Is there a rationale? Has there ever been a rationale for it? Katie's shaking her head.
That's the thing, that there hasn't been evidence about how to use blood, and now is the time when that is actually coming through and making these suggestions for changing transfusion practice. But yeah, basically people use it how they use it because that's how they do it.
I think it's really odd in a world of evidence-based medicine where we think so carefully about everything we do, that actually something as important as blood transfusion, and I've done this, how long have I been practicing medicine for? It's best part of 20 years. You know, how many times have I given blood to someone and just said, yeah, 2 units, 2 units, 2 units, 2 units, 2 units. Although I do give a smidge of frusemide usually. My patient population is very breathless all the time anyway, because they've all got COPD or heart failure and bits and bobs, so I think it's quite a tricky thing sometimes to determine whether to give blood to someone who's got a haemoglobin of 7.8, 78. I think that is a difficult thing to judge, but it's interesting. I like your orthopaedic data that it doesn't make any difference to anybody, and I wonder if we're just what we're doing. I have another question, just a general question, which is sort of stems on from the link I posted in the email, which is, why are we using less blood? The Courier reported that we're using a lot less blood, so we don't need as much donated. Does one of you want to pass a comment on that? If I can make this microphone work. Can't make that microphone work. Try that one. Oh, God. We've got gremlins in the system today. Katie, you're an important person who can talk about that. But Perth can't hear you unless you use the microphone.
So blood use is falling because of things like the pre-assessment clinic in surgery, where patients that are anaemic pre-operatively are identified and have their anaemia treated before they have their operation. So they are less likely to need a blood transfusion because their haemoglobin is optimised pre-operatively. The same in obstetrics, for example. There's programmes for using iron to improve haemoglobin in women, both pre-delivery and post-delivery. Generally sort of patient blood management work that's going on around hospitals, and projects like Karen's, which are just, to say, promoting appropriate blood use, just mean that transfusion rates are falling.
Do you think people are bleeding less?
I think probably that has an element. So surgical techniques like laparoscopic surgery, like using diathermy, like using tranexamic acid pre-operatively in orthopaedic patients, all of those things reduce blood loss. Do you think the demise of warfarin has anything to do with it? These DOACs got anything to do with it? I don't know, actually.
Is that a thing?
Not looked at that. I think it's
probably... Keith's shaking his head. He doesn't believe that. Not yet. Not yet.
But we see, certainly, I think some of the lab staff are here, I think we see fewer really big bleeds than we used to. So there are still people who have major hemorrhage, but they're not major hemorrhages that use 20 units of red cells. They're major hemorrhages that use 6 units of red cells, which is a difference as well. And that probably just reflects early recognition of serious bleeding and appropriate quick intervention, which I think, you know, things like interventional radiology input and all of these things which didn't exist previously are probably contributing to.
Good. Right, does anybody else have any questions? Anyone want to pass comments? Keith, not Keith. David, you want to say that?
I just wondered if England are ahead of us with this because they have to pay for their blood. So does this also reflect the fact that in Scotland we don't get charged for using blood?
There you go, you can play tennis across.
I think that certainly does play into it, because the English teams, so transfusion teams who are trying to say to a clinical unit, your use of blood is not optimal, you could do this, and if you did this you would save however many hundreds or thousands of pounds, or definitely have a stronger bargaining chip than I do if I go to a clinical unit and say, I think you could be doing this differently. So I think that certainly, and we have talked about applying a sort of virtual cost to these things so that we can use that with clinical teams just to kind of highlight savings that could be made.
So is there anything else we should be doing? Anything else? Orthopods need to operate more carefully, and there's all these pre-assessment clinic things. What about in medicine? Is there anything we're doing that's, do you think it's leading to us using too much blood, or what can we do? I took the box. No, well, that's the whole point, Katie. I'm trying to get you started. The microphone doesn't work. Does that one? Yes. Go.
So I think medicine is a much more difficult group of patients to work with because they're such a heterogeneous group of patients. So it's quite easy to say, do a study in orthopaedic post-hip fracture patients or in intensive care patients. But because medical patients are such, as I say, a mixed bag, it's much more difficult to do studies which we can then use as evidence-based medicine in these patients. There are things going on, like I've been contacted this week about an IV iron policy in the medical wards. So again, thinking of using alternatives to transfusion. And I think that probably is already happening, although it's not been formalised. But looking at that and perhaps going with, say, the respiratory team, it's dead easy to get a list of all the blood that's been transfused in Ward 3 if somebody has an interest to then look at the patients, look at the haemoglobins and see what we could be doing differently. So
well, that'd be dead simple, because most of our respiratory SHOs seem to go on to become haematologists. So I'm sure we'll find somebody who's interested.
But yeah, so I think that would be a good thing to do, just to look. And the same with, Ward 4 general medicine and seeing how blood is used in that ward, for example. Okay.
Anybody else got anything? Oh, there's a question at the back, and now I need to take, because you'll need to answer it, and then this microphone.
Hi, I'm just wondering how much cost is involved with transfusing one bag red blood cells compared to how much would you save?
Yeah, so probably about £300 for a unit of red cells.
£300 for 1 unit of red cells.
But that cost is in England. So in Scotland, blood is provided by SNBTS to hospitals without a charge to the hospital, because SNBTS is part of NHS Scotland. So rather than, as I say, charging for individual units, it's paid for by SNBTS.
So here it's free, but technically it would cost £300
exactly.
if you would charge.
Yeah.
So there is a cost involved. I mean, it's just,
absolutely.
We don't see it in NHS side, it's in Scotland. What about other blood products? The non-red bits?
Yeah, everything gets more expensive. George,
a unit of frozen plasma is probably the cheapest. That's about 150. But an apheresis platelet is up towards £500 per platelet. Right. And that's the cost of the plastic to collect and to the time it takes to collect. But all the DAT testing for virology is the expensive part.
Okay, my last question then. If we need less blood, can we stop donating it?
What we want is the right people to donate at the right time. So if you are keen to donate, you need to know your blood group. And
A positive.
Then when there will be calls for specific blood groups, that's when we need you to donate. Right donor, right time.
Are there peaks and troughs? Are there times that,
Yeah,
donate before
absolutely.
Christmas?
Yeah, absolutely. Yeah. And there will always be there's kind of social media campaigns and things in the run-up to summer holidays and that kind of thing, same before Christmas, to try and make sure that we have enough donors coming through the door to cater for the needs of the patients.
Very good. I'm very carefully made sure my entire family is A positive, so if I have anything horrendous happen to me, which is likely, obviously, because I'm always sick, I can just draw on my wife's blood. It's absolutely fine. Okay, any more questions? Anything? I think this is really important stuff, this kind of... I like these kind of grand rounds where I sit there and think, crikey, I've been doing something stupid for all this time. I think are really valuable. I'm very sorry that there wasn't a bigger audience, but I can tell you that it has been videoed, and the university has agreed now to put them all back online again. So thank you to all of you who wrote in so I could use that evidence that they're valuable. And I will write something witty, pithy, and informative in next week's email all about blood transfusion, because I think it's really important people know about this. If you give me some of your slides, I might even throw them in. Okay, next week it's LGBT group. It's LGBT month this month. So next week we hand over to the LGBT team, who are going to talk about bias of gender equality in the workplace, particularly with a focus on students. So it's very interesting stuff. Please come along. Thanks once again to Karen and to Katie and to everybody else on the haematology team. Thank you very much. And to the mysterious voice from Perth, of course.